Okay, so we got lid, anterior chamber. Okay, what's this? Iris. Once he gets a really good view, you'll be able to see the, it's clearer on his machine than it is on the screen. But see, now you can see the whole vitreous body. Sometimes in a certain view, you can see the back of the lens here. That little thing that flickered right there is the lens. And then he's going to get it where you can see the shadowing back here on the optic sheath nerve diameter. You can see a little bit of optic sheath right there. And at some point, and there's the lens, that's a really good picture. You can see the shadow. At some point, he'll freeze it. All right? He's going to go back till he gets a perfect vision or view there. He's got it frozen. He's kind of using the mouse pad to go back. And then he's going to drop some calipers back here. Remember, where's the first set of calipers? He's going to hit the caliper button. Caliper, that's right. He's going to put one at the posterior area where it's real white in the posterior chamber. He's going to drop his calipers down exactly 3, and you can see down here how many I'm sorry, up here. Here's the distance. So it says he had it 0.3. It's very sensitive, so sometimes I'll take off my glove and use the fat pad of my finger. He dropped it down 0.3, and then now he's going to put his second set of calipers even with the bottom 0.3 one and go inner wall to inner wall. So he's going to stretch that out. It's got to be straight, which he's doing right now, and it should be less than 5. Is that less than 5? So it's perfect, right? So he does not have increased intracranial pressure. So that's a good view in the transverse. So one thing he's going to demonstrate in just a moment is the dynamic exam. So we're looking for vitreous detachment, vitreous hemorrhage, retinal detachment. He's going to put it back on there and go left, right, with the transverse view. So that's a probe marker to the patient's right. So that was the static exam, and this is the dynamic. Whatever.
So what I do is I also turn up the gain when I ask him to do the dynamic, and I'll turn up the gain when I ask him to do the dynamic view so that you can see some of the particulates in the back. So go ahead and move your eye to left and right. And you can see, I'm pointing here. You can see on the screen here, as I move either way, what they call like a washing machine sign or something like just kind of swirling around like you would imagine your clothes in the washing machine if you have a front loader. And that would be posterior vitreous hemorrhage, which is not an emergency, but it's still urgent and should be dealt with.
It could be a dryer. I mean, clothes go around with a dryer too.
But I don't know if you saw, I also decreased my depth when I was looking for that because I wasn't as worried about the optic nerve sheath anymore. So I was saving the processing power and distance.
He already measured it, so now he's just worried about the dynamic exam and what's back there.
Then I'm going to turn my gain back down to make the blacks and and then we're going to go through, this would be the static part where I'm going to run through. So then I'm going, oh, that's really loud. So then I'm going to run through on the static display and just go, just like we did with the bladder or any cystic structure, from top to bottom, looking for anything down here or anything that should be abnormal. And I'm going to rotate my probe 90 degrees towards the patient's head, and then find again, and go back and forth.
So.
Does that make sense? And then you can also turn on the gain on the top one and ask him to move. Now this would be up and down.
Yeah, when the probe's towards the head, it's just up, down, and that helps you with your the actual muscles that that control your extraocular movements. In case there's like an orbital fracture and there's entrapment, you can actually see if the muscles are working or not. So that's actually really helpful, especially with eye trauma. Awesome.
The next one's going to be DVT. We use this leg.
So he's going to get it chucked, so we're going to kind of tuck it into the underwear and stuff because you're going to get really proximal. And so sometimes these shorts, these are the same army shorts I had. They work whether you put them on frontwards or backwards, right? The shorts, you can wear them either way. That's how terrible they're made.
Now where did I take the mic? Then I started talking over you.
It's okay.
It's just rude.
It's okay. I anticipated it. It's okay. There's a bird?
Yes.
A little bit or a lot of it?
A little bit.
See?
Okay. It's annoying. It's not bad. Okay, so now we're going to be doing the DVT, which we already kind of talked about why. And you want to get a lot more proximal than you think. And then one of the challenges is this is a fairly narrow footprint. Some of the other linear probes are a little bit longer. But people get upset if you go to the curvilinear. But know that you can, because right, this is a similar, you sacrifice a little bit of the resolution, but it's a similar option. So we're going to go cold gel. And change to,
So I have it on an ophthalmic preset right now for eye. Now he's gonna go venous or vascular preset.
I know I talked about this with some of the groups last week. With the eye, it's really important that you do that ophthalmic preset because it decreases the mechanical and thermal index, the amount of energy that's being transitioned into those small sensitive tissues in the eye. Right? We don't want to lose this vision because we're practicing scanning. Okay? We don't care about his leg though.
So you'll see layers. You'll see adipose, everybody has it. You'll see muscle layer. And again, sometimes we'll have, this is our depth in the bottom right. That's 4.5 centimeters. Some of you will be a lot more superficial, some of them a little bit deeper. And you're looking for Mickey Mouse's face, the two ears, and you're looking for the saphenous spilling into it. All right, depending on, he's doing the right leg. So the vein is always medial to these structures. Okay, so he's on the right leg, so the vein is medial to the arteries. And if you're on the opposite leg, it's going to look opposite. Okay.
So everybody can see, I'm going to switch to the curvilinear probe. Maybe.
Sorry, I'm just dying.
You're dying because you're sick?
Yes.
Can't just talk about I appreciate your dedication to being here. At least you're wearing a mask. Thank you.
All right, take two.
The probe markers to the patient's right. Okay, you don't need to do a linear. We're just doing transverse. Okay, that's all we're doing. One view, 3 points.
So you can see.
Here, right here. Here's the complex here. And so he's got a bigger probe so he can actually see more of the tissue around. But we got the arteries here and he's compressing the vein. And we're trying to get up real proximal. And some people it's a little more distal, but we're trying to get where that saphenous is spilling into the common femoral vein. And you notice the arteries are not compressing. So he's got that whole saphenous process here spilling into the common femoral vein. It's hard to see, and it looks a little bit different slightly in each other, but from person to person, but you guys will do it enough that you'll get good practice. So once he scans a little more distal, then you'll just see that it looks like one artery, one vein has come together, because the two arteries now have, instead of bifurcated, they're in one structure, and now it's artery and vein, and just the vein underneath is compressing. That's your midpoint. Okay, which is really still pretty proximal in the leg, okay?
I'm just going down the whole way.
So he's compressing every couple centimeters, and what you'll see is around mid-thigh, the vein dives down and you can't see it anymore. All right, so then we just go popliteal. So he's doing every couple centimeter compression, which is how I learned, but you could just do 3 points is all you need to do. And then he's done with that, now he's going to popliteal, and you can see it pops on top once he gets a really good view. Here's the popliteal vein, here's the artery, pop on top, and he's compressing the vein. And it's easy to slip around in there because you're in that little popliteal fossa. So it's pretty simple, right? Pretty straightforward, do you think? You'll have a better appreciation once you put your hands on it. So, real simple. We can do it in a couple minutes at the bedside. Obviously, if you had a PE, we do both legs, but for your purposes, you're just going to do one. And the way we demonstrated, the way your cheat sheet is, that's the right leg. So if you want your anatomy, when you're looking and trying to learn this to look just like your cheat sheet, just do the right leg of your patient, not the left. Otherwise, everything's backwards. Just keep it simple for yourselves. Any questions about these? Okay.
It's important to make sure, I'm sure Dr. Ketchum already said this, it's important to make sure that you compress and watch that artery pulse, because otherwise you might actually have a redundant vessel, like another vein that could be occluded.
Okay. feel free if you guys want to try to practice. I know there's not a lot of class time left. It's like 15 minutes. Also, like I said, I'll be here at lunch. If you guys want to practice during lunch and get up in your groups, there will be also dedicated class time. So next lecture time is just dedicated class time to practice. But it's important that you get reps in. The more, the better.